And welcome to today's webinar on sexual myths. If you don't know much about Forest, we are a private, non-for-profit institution offering 4 master's programs and a doctorate. We have a master's in clinical psychology, a master's in counseling psychology, a master's in marriage and family therapy, and a master's in applied behavior analysis, along with 2 certificate programs. Our doctorate is a PsyD, and I'm going to go ahead and introduce our presenter today. Afterwards, if you have questions about our programs, we will stay on the line and we can answer any questions that you might have. During the presentation, there will be an opportunity for the participants to vote. So a poll will pop up on your screen and you will have the opportunity to answer the poll question. So let's go ahead and get started. I want to introduce our presenter, Dr. Ginger Holczer. Dr. Holczer is the director of the Master's in Counseling Psychology program at the Forest Institute. She earned her undergraduate degree from Missouri Southern State University, a BS in psychology, and she earned her doctorate from the Forest Institute. Dr. Holczer is also an ASEC certified sex therapist. So welcome, Dr. Holczer.
Welcome, and I'm so glad to be doing this webinar, especially on such an important topic as sexuality. And these webinars are such a good way to get information out there and have interactive conversations about different topics in the field of sexuality or in the field of psychology. So I'm going to get to the sexual myths that I proposed to you in just a few minutes. But first I want to spend just a few minutes talking about why it's important for mental health providers to know a few sexual facts. The World Health Organization in 2004 gave us the idea that sexuality is a fundamental aspect of a person's life, and also that it's related to physical and mental health. As therapists, if we don't allow a place for sexuality in the therapy room, we're leaving a fundamental aspect of our client's life outside the door. Sexuality is a deeply personal and often taboo topic for both clients and therapists, and it can cause anxiety and uncertainty. So clients might have difficulty bringing their sexual concerns up to the therapist, and when they do, therapists sometimes have apprehension about how to address the sexual concerns that they do bring to the room. And even though our nature and intention is to be respectful and compassionate, sometimes we tend to drop the ball when we feel incompetent to address those sexual issues. So if you think about it, as therapists, there are many places that we might feel incompetent about an issue in a client's life. For instance, we might not understand necessarily somebody's ethnicity or the kind of grief that they're going through, or maybe couples' relationship issues. And we tend to kind of hang in there with them and deal with it, but sexuality seems to add another level of discomfort to the whole mix. So now we're going to do our first poll question. And the question is, how many psychologists ask their clients about sexual concerns? We've got less than 50, 75%, 84%, or 90%. And you're all right, less than 50%. Research found that over half of the clinical psychologists that were surveyed rarely or never asked clients about their sexual well-being. And I like that they use the term sexual well-being. They're not asking about functioning or necessarily the mechanics of sex, but how are people doing? You know, what are they feeling about their sexuality? What's going on? So we don't necessarily need to know the mechanics of sex to be able to empathize and deal with some of the issues in sexuality. We do know from a lot of research that many individuals won't discuss sexual issues unless the clinician brings it up. And not only bring it up, but demonstrate kind of an openness and an ability to be comfortable with the topic, even though sexual concerns might be relevant to the therapeutic goals. So this could be as simple as asking about sexual concerns during an initial intake session, as well as being conscious that not everyone is in a traditional opposite gender relationship, There's all sorts of variations when it comes to sexual behavior, and that's all for another webinar. Bill Staten is a sexologist, and a very good one, and he gives us the notion that we grew up in the same culture as our clients, and we often got negative messages about sex in our culture, and the need to keep quiet about it. And as a therapist, our clients may perceive us as an expert, yet a lot of times we might know less and be even more confused and secretive about sex than our clients are, even when we have adequate sexual knowledge. And so the important thing is we need to examine our own life messages about sex, and when the issue of sex does come into the therapy room, we need to be really cautious not to perpetuate, stigma and shame that our culture tends to place on sexuality, and kind of look at our own anxieties and our own biases surrounding sex so that we can address that before our clients address it with us. And another question. So as therapists, what is the most common failure when it comes to sexual issues? We've got inappropriate affect when we're nervous, giving wrong information, making our clients feel bad for asking, or avoiding the issue altogether. Well, you guys are really good. Yes, it is the failure of therapists to avoid the issue of sex altogether, which is also research-based. That's what the research says that we do, is we tend to avoid it. So when I'm talking about sexual issues, what specifically am I talking about? What kinds of things might a client bring into the therapy room? The first being a person's sexual orientation or gender identity. There might be coming out issues. There might be confusion or exploration surrounding sexual orientation or gender identity. A person's ability to become aroused sexually. Some people struggle with sexual pain. A person's ability to respond in a sexual manner. Sometimes poor body image can affect sexuality, so helping a client maybe be more in the moment instead of in their head about what they're looking like, and focusing on the moment. Sexual abuse, discrepancy in desire. That's where one person might think a sexual experience 3 times a week is important, and the other person might think 2 times a month is great. So that discrepancy in their desire. Also feelings regarding fantasies, desires, or sexual propensities. So some people might have fantasies that they are troubled by, or desire certain things that they might feel is abnormal. And we'll get more into that later. But those are things that somebody might bring into therapy as well. And then a person's ability to experience sexual pleasure altogether. So those are some of the things that people might talk about in therapy. And another question. What percentage of the population will experience a sexual problem at some time during their lives? We have 12 to 20%, 25 to 33%, 31 to 43%, and 55 to 73%. And looks like we were pretty divided on that one. The answer, according to Lauman et al., 31 to 43% of the population reports some sort of sexual problem during their lives. The problem is only 10 to 20% had actually seen a clinician for the problem. So that's quite significant. So as therapists, our job is to normalize and educate. You may not have the answers right away, but there are ways to get a little bit of information about human sexuality. There's great books out there, and I'll give you some resources at the end of the webinar. There's also CE workshops, webinars such as this, where you can at least direct your clients to places they might find the answer. It's been my experience with clients that they would rather hear me say, I don't know the answer, but let me help you find it, than for us to avoid the question or perpetuate shame, which just, carries on that notion that we should be silent when it comes to sex, or we should just avoid that issue. So the notion of normal, and what is normal when it comes to sexuality, and that is such a broad topic, and again, that could be a whole nother webinar. But for the most part, we all fall somewhere in a continuum. One thing we know is that change is inevitable. Sexuality changes throughout our lifespan. Illness, aging, life stress, different stages of life, all those things can change the course of what people consider normal in their sex lives. If you think of somebody who might have like prostate cancer, gynecological cancer, or had a stroke, or maybe has diabetes, so the blood flow that is needed for erections and arousal isn't there, they have to come up with a different way to be sexual. And so normal just keeps changing throughout our lives. Also, individuals, when they do discuss issues that are directly related to sex and therapy, that's great. But there might be issues that they come in with that may be affecting their sexuality. So it's more indirect kinds of problems, not necessarily what they came in for, but the issues that they're coming in for may affect their sexuality. Things like depression, anxiety, relationship problems, eating disorders, illness, medications, sleep disturbances, all of those things can affect sexuality and affect the way we're sexual with ourselves and with each other, as well as some of the more serious things like PTSD, bipolar, schizophrenia, personality disorders. All of those things can affect a person's sexuality as well. So we have to be aware of that too, that even though they're not saying that it's a sexual issue, what they came in with might be affecting sex. I want to talk a few minutes about communicating about sex. It's one of the most important parts of sexuality, regardless of what a person comes in with or what they might be feeling. Being able to communicate that to the different helping professionals in their lives or even their partners is so important. So although sexual expression is fundamentally important, and we talked about that earlier, most people do not communicate about sex even when it's important to do so. So they're not talking to their doctors, they're not talking to their therapists, and they're certainly not talking to their partners when it comes to sex. I remember the reason I kind of got into the field of sexuality. I had a couple that I had seen maybe 6 times, and we just didn't seem to be getting anywhere, and it seems like there was something there that wasn't being said. And thinking about their story, I wondered if it was sexual, and I had never brought sexuality into the therapy room prior to this, but this couple, there was something unsaid, and so I decided I was going to bring the subject up. And I have to admit, when I went into the room, I'm pretty sure my face was red, I'm pretty sure I was pretty uncomfortable. Of course I didn't want to make them uncomfortable, but I just felt like it needed to be said, so I sat down and kind of blurted out, "Tell me about your sex life." And the gentleman in the couple got really tearful. And he said, "I miss her. I miss the way we used to be." And that's such a big part of the problem. He said, "You're the 3rd therapist we've been to, and nobody's ever brought it up before." And so they were able to open that door and discuss it a little bit. But it was a struggle for me, and it was a struggle for them. After that, I decided to ask a lot more questions, and decided that that was an area I wanted to specialize in. So that's the route that I went. But you don't have to specialize in sexuality or become a certified sex therapist to allow the topic to come into your therapy room. When you start building trust with somebody and that therapeutic alliance becomes stronger, you become more emotionally intimate with each other, it's more apt that the subject might come up, that the client might feel comfortable enough to go there. And I've had several clients in my office who would start to bring up the subject of sex, and then they would kind of cover their mouth and say, "Oh, can I talk about that in here?" And so they don't necessarily know if you don't allow them to know, if you don't open the door that they can talk about sex. So if a client brings up sex and we don't address it, again, we're perpetuating that whole shame, embarrassment thing that society has kind of mandated regarding sexuality. And we can normalize our clients' concerns, provide education, and also help them to have a voice. There's times when I have clients that need to talk to their physician. They're nervous about talking to their physician, and so helping them to find that voice. And I've spent several sessions just talking about how to talk about it, with a physician, with a partner, whoever they might need to inform that there's something going on that they need to discuss. I want to show you a little bit of a video that will kind of give you a little bit better idea of the importance of talking about sex. And this is a TED Talk that Dr. Jen Gonzalez did, and she's a sex therapist in San Diego. She does all these really cool YouTube videos. She calls herself Dr. Jen in the Den, and they're very, very funny and sometimes lighthearted and sometimes very serious topics. They can be a little bit racy, so you might want to be aware of that, but for the most part they're pretty good. So I'm going to show you just a little bit of this, and we'll get back to our sexual myths conversation. Okay, so I just wanted to give you a sense of another idea of why it's so important to communicate about sexuality. And again, that's Dr. Jen in the Den on YouTube. If you have any kind of sexual questions, I think she's addressed them all, including communication. So we're going to move on to the part of our webinar that actually talks about the sexual myths. So the first thing we'll start with is another poll question. So when it comes to the appearance of female genitals, women tend to all look fairly similar, have a similar shaped clitoris but labia differs, have similar labia but the clitoris differs, or vary greatly in shape and size. So very true. It is a myth that everyone's genitals are similar, both males and females. Women tend to have very different looking vulvas. Excuse me. The labia is usually asymmetrical. It can vary greatly in shape and size, as with the clitoris. So there's been workshops that I've done with women, and I show them pen and pencil drawings of vulvas, different shapes and sizes. And I've even had women say, I thought there was something wrong with me. I had no idea that it was okay to look this way. We just don't seem to know what we should look like other than what media has portrayed, what we've seen in magazines or something like that as to what a vulva should look like. So, yeah, that's a myth. Penis shape and size greatly differs. Some are circumcised, some are uncircumcised, some are different lengths, some are different girths, so that's very different as well. And there's also people who are intersex. And what that means is they have ambiguous genitalia, because we're all on a continuum, from male to the other extreme, female, and some people fall in the middle. And actually 1 in 1,500 to 2,000 people have ambiguous genitalia. So you can see that we all look really different, and it's okay. It's really okay to look different. It is a myth that size matters. Am I really going to go there? Yeah, I'm really going to go there. Although we always hear that size doesn't matter, why doesn't it? Other than the idea that, we really care about this person and that part isn't the most important part, there are some physiological reasons why size doesn't matter. The first thing I want you to know is that a woman's vagina is such that most of the nerve endings are close to the opening. So like the bottom 1/3 of the vagina, which is closest to the opening, is where the nerve endings are. So the vagina as a whole doesn't have the nerve endings necessary for sexual stimulation and orgasm, so just the bottom 1/3. The other thing I want you to know is that the average vagina is about 3 to 4 inches long, and a penis averages about 5 to 7 inches. So the vagina, when it's sexually aroused, expands by about 200%, kind of like a balloon, but it also tends to adjust to the size of a penis. So with a smaller penis, the vagina the walls tend to close up around the penis. So our vaginas are very elastic and can fit a lot of different sizes. It's a myth that erections don't go away. I get a lot of couples in my office that think that there's something wrong because a man's erection throughout a sexual encounter kind of waxes and wanes, but that's perfectly normal. And also women that think I can't keep them turned on or something like that. Actually, during about a 45-minute pleasuring session, erections can wax and wane 3 to 5 times, and there's nothing wrong. It doesn't make a person abnormal. So, another poll question. And the question is, do men and women take the same path to arousal and orgasm? And the options are yes, no, yes when the relationship is new, and yes when two people have been together for a while. Yeah, and the answer is kind of a trick question. It's kind of a trick question because the answer is no, but we'll talk about when the relationship is new in just a minute. When it comes to women and men's paths to arousal, a man's arousal pattern takes kind of a linear path, and so they go through the stages of excitement, then it kind of plateaus and they're there for a while, and then orgasm resolution. And I'm going to show you a visual of this in just a minute so you can get a better idea of what I'm trying to say. A woman's arousal pattern, however, is more circular. Women often go through the day in kind of a neutral sexual state in which she doesn't necessarily feel much desire. At some point, a woman considers her own motivation to have sex, such as a longing to feel loved or accepted or some kind of emotional benefit. Then these personal motivators lead to a deliberate choice to be sexual. And then that may lead to arousal and the awareness of desire. So this is kind of a visual of what I'm trying to explain here. And so you see on the left with the males, you have desire, then it goes up to a plateau where you go along for a while. With men, there's the idea at some point of an inevitable orgasm. Then they have a refractory period where the males have a period where they have to rest before another erection is possible, and then resolution where everything comes on the downslope. So that's tends to be the pattern for males. Masters and Johnson came up with this, and it's been consistent throughout time. One thing that we have found, though, is that women who are in new relationships or women who are in long-distance relationships where they don't have a lot of sexual contact with their partner tend to take this same linear path. So those are the conditions where women might follow the same path. On the other side, you see the right side where we're talking about women. There's a very clear start point where you're sexually neutral. You get some sort of stimuli that says, I might be okay with this. I might want to experience some stimuli here. And so she might engage in that. There would be some psychological maybe and biological kinds of stimuli that happen. It might be feeling closer to the person. It might be touching each other that makes the woman want to continue on and continue being more sexual. So it's kind of this conscious choice. And then that desired arousal kind of prompts us to continue on through the cycle, and then the pleasure of the body and the mind kind of come together and intimacy is achieved. And so we get to our goal being emotional intimacy. So that's kind of the pattern that women take, and it was developed by Rosemary Bassan And several other people have come up with similar kind of circular ways of looking at arousal. The notion that most women can orgasm from intercourse is a myth. The reality is that only 1 in 4 women can actually orgasm through intercourse alone. And if you remember, we talked about the nerve endings in the vagina. So, and there's a lot of variables that go along with that. The way our genital structure is. But most women need clitoral stimulation. The last figure I heard was 71% of women needed clitoral stimulation along with intercourse in order to be able to orgasm during intercourse. And that's quite a big number, and a lot of women don't know that, and nor do a lot of men, by the way. Our society thinks that men should be sex machines, that they should always be ready for sex, they should know how to do it, they should know how to initiate it, they should want it, even if it was somebody they don't necessarily care about or with whom they're uncomfortable. And that's not true. Men aren't sex machines. And you know, it's funny, when I got to be certified as a sex therapist, I expected that I would hang my shingle as sex therapist and have a lot of women with low desire, or maybe some sexual orientation exploration or something like that. And I got a lot of men. I got a lot of men who had performance anxiety, were unsure how to approach women. So they're not sex machines, and we need to help our sons know that it's okay to ask questions and it's okay not to know. Real sex is not always intercourse. In fact, when sex equals intercourse, intercourse becomes a goal, and that causes pressure. That means that we have to, go from point A to point B, or it's wrong, and that's not the case. Intercourse isn't always the best part of a sexual interaction, and it's also really freeing and fun to think about sex in its entirety, all the playful, exploratory kind of fun that goes on all during a sexual encounter. And also, to do that, to not make sex or make intercourse a goal, it invites relaxation, mindfulness, and acceptance into the experience that you're having. Also, intercourse is not always possible if, for whatever reason, maybe aging or illness, or for whatever reason, intercourse is no longer an option for people. Helping our clients to understand that there are other options, that there are other ways that they can be intimate and sexual, other than having intercourse. I remember talking to a gynecological cancer group where one woman asked me, "Why do I want to have intercourse? My body has been so invaded, and I have no desire, but I do want to be sexual." So helping them to understand that there's other ways. Also, when it comes to orgasm, they're not always easy. Some people have a lot of difficulty, and that could have physical causes. It could also be the result of having a fear of letting go, or maybe some control issues or something. But anyway, 75% of men and only 29% of women always orgasm during sex with their partner. And some of the reasons for difficulty might include hormone levels, the technique the couple is using. It might be that they're tired, medication they might be taking. They might have some sort of interpersonal conflict that's put a wedge into their relationship that's causing problems, stress, substance abuse, and the list goes on. There's a lot of different reasons why that might be occurring. We would love for sex to be spontaneous, but for the most part, spontaneous sex is a myth. And if you think about it, is it ever really that spontaneous? If you are having a great time with your partner and you're thinking, this might happen, what do? You go take a shower, you clean up, you comb your hair. If you think, that the kids are gone tonight, so let's live this up, and you cook a great dinner, candles. So is it really ever that spontaneous? And also, planning sex can be really fun. And if you think about me telling you earlier that women start out at neutral, planning a sexual encounter can take us that step up from neutral to I'm aware and I am thinking about the possibility of being sexual. From the media, we get the idea that everyone is having great sex except for me. It's really self-defeating to make comparisons like that with other people. And when we do, we're kind of looking at somebody's outsides with our insides. So we're looking at them, thinking how we're feeling inside, and it's not fair. It's not fair for us to do that to ourselves. Everybody has problems. Everybody has, incidences where things didn't go so great, and it's okay. It's just a matter of what do you do now. If somebody comes into your office and they say that they are having same-gender sex but they're not gay, that might be true. They're not necessarily gay. There are three aspects to sexual orientation. There's romantic attraction, there's our sexual behavior, our actual sexual behavior, what we do, and then also the identity that we define ourselves with. And so there are heterosexual males and females that have same-gender sex, and it doesn't make them gay. There's different parts of this, of those three aspects that might be in play. It might be that they have the attraction and they're doing the behavior, but they don't necessarily identify, or maybe they are acting out the behavior, subscribe to the identity. There's different combinations that can happen there. And so there needs to be more than just attraction and behavior in order for somebody to actually be a homosexual orientation. And another question. And the question is, sex should be an amazing experience every time. You guys are quick. Holy cow. Answers are, of course, not always, only in the beginning, or the last option after you've been together for a while. So we have some kind of mixed ideas, and the answer to the question is that it's a myth that good sex is mind-blowing sex every time. So there are times when it's not a great experience. Metz and McCarthy, they gave us the notion of good enough sex. And what they said was every sexual encounter isn't perfect, and the quality of sex varies with every experience. So they said 20 to 25% of sexual experiences are very good, mind-blowing, saw fireworks, that was awesome kinds of experiences. 40 to 60%, it was good. 15 to 20%, it was fair, it was okay. And then there's 5 to 15%, and this is with each couple is what they're saying, that's dissatisfying or dysfunctional. It just didn't work out right for whatever reason. Maybe somebody was too tired, it just didn't work out right. And so learning to help our clients understand that, when things go awry, when things are in this 5 to 15% range, it's okay to maybe laugh it off or say, chalk it up to we won't do that again when we haven't had any sleep, or, that's not a good idea with the kids awake or whatever. So trying to find a way to accept that 5 to 15% and even the 15 to 20% that's just fair. It's also a myth that sex is over after the age of 60. The New England Journal of Medicine did a survey with 3,005 people between the ages of 57 and 85. And what they found was a significant amount reported being sexually active later on after their 70s. And the reason why they did stop when they did stop was not because of lack of desire. The reason they stopped was either they had health problems that were preventing them from having sex, or they had a lack of a partner. Somehow they had lost their partner. Of those people in that age group who were sexually active, most said they were having sex at least 2 or 3 times a month. And one thing to note is that sex after 60 generally follows the same frequency patterns as sex in our younger years. It may not be the same sex. The part where I talked about normal and finding different ways at different life stages, is true, but the frequency seems to stay the same. So if a couple in their 30s tended to have sex twice a week, when they get older, they very well might keep that same frequency as long as health is good and there's still a partner there. There's a lot of great books that you can take a look at that will give you a lot of information about sexuality in a lot of different ways. So if you feel like this is something that you should be presenting to your clients, or something that the door that you should open, these are some resources, and there's definitely a plug there for the book that Dr. Bennett and I wrote. But it is a good guide to learning how to communicate about sex, and it's even got a chapter in it for therapists. It's got a chapter in it for doctors and a chapter for even talking to your kids about sex, so it's a good resource. Sally Foley, Sally Cope, and Dennis Shagru wrote Sex Matters for Women. It's a very comprehensive book that gives a lot of information. Marty Klein wrote Sexual Intelligence, What We Really Want from Sex and How to Get It. It's a really good book for kind of looking at your own biases, looking at your own stuff, and trying to figure out where you're at with sexuality so that you can be there for your clients in the therapy room. And Emily and Barry McCarthy wrote Sexual Awareness. It's got a lot of good solution kind of focused information regarding sex. And then Joan Price, Talking Out Loud About Senior Sex, Naked at Our Age. It's a really good book too for looking at sex with older adults. So that is the conclusion of the webinar part, and so now we'll open it up to questions. Okay, so my first question is, what is the biggest population of people that I see in sex therapy? Probably, I would say, people who are having difficulty with that whole idea of normalcy, with, they have to make changes. This is how sex has always been. How do I make it different? That is probably one of the biggest issues that come up. Another question, how can a therapist tactfully address problematic sexual behavior such as promiscuity, unprotected sex with children and early adolescence? Well, that's a great question. There's a lot of stuff that goes along with that, especially with, how involved are the caregivers in that situation. There's so many things that go on with that. But basically, what is it that they're trying to, really trying to get? Do they need attention? Are they looking for affection? What kind of things are they trying to get? And hopefully there's a caregiver that can be helpful to them and can consider some of those things with them. The question is, will the PowerPoint be emailed? The PowerPoint will be available on the website, so you have access to it. Another question, the most direct path educationally to becoming a sex therapist is contacting ASECT, which is the American Association for Sexuality Educators, Counselors, and Therapists. It's asect.org, and that's the best way to become a sex therapist. Any education that you might have, any kind of CEs or anything like that you might do that are sexually oriented, keep track of all of that, because all that counts. Even classes that you took as far as undergrad, as far back as undergrad can count, so if you ever took a human sexuality class or anything. So basically that's the best way to go, and then you have to have some supervisory experience as well through ASECT. The next question, other than the book you mentioned, are there any good resources that could be used in training staff to become aware of and set aside their biases when working with client sexual issues? If you could send me an email through my Forest account, gholczer@forest.edu, I have a list of books, and I can certainly get that to you. I can't think of the name of it off the top of my head, though. So, but I appreciate that question because I think that's so important. We all need to really consider our own biases when it comes to sexuality. Yeah. Any more questions? Well, thank you so much, and I've enjoyed doing this, and hopefully they'll ask me to come back and do some more on sexuality. And I'm going to turn you over to Kim Ramacati.
Thank you, Dr. Holczer. Just in closing, I wanted to post our 800 number. It's 1-800-424-7793, and our website is forest.edu. And if you have any questions about our school or any of our programs, we would love to talk with you. You can also email admissions@forest.edu. So thank you for joining us today, and please check our website for upcoming webinars on other relevant topics. Thank you so much. Bye.